Awesome. All right. Thank you, everybody, and welcome to our second session today on our Project Echo program on tools and strategies for nutrition and exercise quality improvement. So, in today's session, I just wanted to make a clarification. We're going to be talking about strategies to reduce weight stigma. I think we needed to make that correction where originally we were going to have content about motivational interviewing today, but that will be covered during our third session. But anyway, thank you so much for joining us, and we're going to get started. So just a few housekeeping items. Just a reminder to everybody that your line is muted upon entry. Please make sure that you engage in the chat. Please also raise your hand if you would like your line to also be unmuted. So one of the distinctions with their Project Echo sessions is that they're meant to be engaging, and they're also meant to have participants collaborate and participate during some of the questions that we will be asking during today's session. So if you like your line to be unmuted, you can raise your hand. And but if we understand that you are also probably during your work hours, so if you cannot speak verbally or participate verbally, then you can also chime in the chat. So this meeting is also being recorded. The slides and the recording link will be sent to you all via email after today's session. The slides are also available on the Project Echo platform. And also, if you're new to this session, please let us know your name, the organization that you're joining us from, your title, and what state, and also what brings you here today. So about the National Center for Health and Public Housing, NCHPH is the mission of NCHPH is to strengthen the capacity of federally funded public housing primary care grantees or health centers and other health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. So just a brief introduction. My name is Fide Pineda Sandoval, and I am the TTA manager here at NCHPH. And with me, I also have my colleague, Olajumoke Oladipo. You can also call her Jumoke, and she's in the line, and she's our health communications and research analyst, and we will be moderating today's session. And then, of course, we have our special speaker for today. His name is Dr. Jose Leon. He's our Chief Medical Officer. And just in case this is your first time joining again, he is also the Chief Community Health Officer at La Maestra and also helps support health centers in developing training and technical assistance programs nationwide. All right, now without further ado, I will pass it on to Dr. Jose Leon to get us started with the rest of the session.
Thank you, Fide and Shimoke, and good afternoon, everyone. It's such a great pleasure to see you again today, March 18th, very close to the equinox, and yet very cold here in the DC area. We are about at 38 degrees. The low are going to be around 20. So we are just waiting for the spring and the cherry blossoms in this area. But thank you so much for joining. It's such a great pleasure to see you all. Next slide, please. Just a very brief recap of what we discussed last time. We went over some data on nutrition and obesity in the United States and the world. We have a brief conversation about challenges that patients and healthcare settings have when you have encounters with your patients and you have a conversation about obesity and nutrition. And then we went over some strategies on how to speak to our patients about obesity and overweight, and making sure that if we notice our patient if we diagnose our patient that the patient is either overweight or obese, this is something that we need to bring to the conversation in a very respectful manner. And we went over and discussed some strategies. Today, we are going to go over stigma. The American Diabetes Association has some new guidelines, and specifically, these are the dietary guidelines from the American Diabetes Association. At this moment, they have developed three chapters, and one of them is on stigma, a very important topic when we have conversations with our patients, and is going to affect not only the health status of our patients, but also it will cause some behavioral issues. So we need to be very respectful on how we speak with our patients and how they identify themselves and how they see themselves if we have a conversation about obesity. So before we get started, let's have, since this is an interactive session, we have some poll questions. And the first question is, next slide. Okay, let's focus on the first one. Research evidence indicates that weight stigma can contribute to the following psychological consequences, except for which? A, depressive symptoms. B, post-traumatic stress. C, substance use. D, suicidal ideation.
You may provide your response in the poll that is should be showing up on your screen. You will see all of the three questions. So, if you can, please hold on until we get to the other two questions to respond.
All right. Thank you, Fide. And the right answer for this question is B, post-traumatic stress. The other three are linked to patients, specifically patients who are or somehow are being stigmatized because either they are overweight or obese. Thank you so much for participating. Next question, please. This is another one. Which of the following can contribute to poor health? A, experiencing weight stigma in an interpersonal interaction. B, being exposed to weight stigma in the media. C, internalizing weight stigma. And D, all of the above.
There you go. I'm so sorry. I just relaunched the poll, so you can go ahead and answer to the second question. Okay. So for the second question, 100% said all of the above.
Excellent, and that is the right answer for this question. In reality, people who experience weight stigma have issues when they have interpersonal interaction, and they are also exposed to weight stigma in the media, and it's very difficult for them to find really good health outcomes if they internalize weight stigma. So thank you so much. And we have one more question. Next slide, please. Okay, research evidence indicates that weight stigma can contribute to the following psychological consequences, except for which I believe that this is the second question, Fide. The one
Yes.
just put, well, this is the third one, the one that we are planning to do.
Yes. So the third one, according to longitudinal evidence, weight stigma predicts which of the following outcomes over time. You should be able to see the third question in the poll. There you go.
I still see number one, Fide, so.
Oh, you have to, if you scroll down, then
Oh,
you'll
okay,
be,
got you.
yeah,
Sorry about that.
no worries.
And the answer is weight gain. We had an 80% of the participants answering this right. So thank you so much. That is the right answer as well. Next slide, please. All right. So before we get into weight stigma, just a quick question, and this is an open-ended question. Can you mention in the chat some forms of weight stigma that you have seen, either in the clinic, in healthcare settings, when people are exposed to the media, when they have interpersonal relations with others? All right. Next slide, please. So there are very different types of weight stigma, and somehow patients, overweight patients, or patients who are overweight, experience some type of a stigma, and specifically in the society, in the community, when others make fun sometimes, and it will depend even the culture. Uh, and I can say that in the Latino population, is very common to make fun of people who are overweight. And that causes a lot of issues, not only psychological issues, but also the health outcomes of our patients are different when we compare them to patients who are not overweight or obese. Um, but we have different ways. We have teasing, bullying, rejection, prejudice, unfair treatment, and discrimination. Is extremely common to see that we also stereotype patients who are overweight. We call them lazy, that they don't have the self-discipline, that they don't like to exercise, that they are just in front of the TV, that they don't have um, really good interaction with others. And all these comments affect the results and the health outcomes of our patients. So is very, very interesting to see how our comments, on the power of our words can affect our patients. And yes, not taking health complaints as serious as doctors at doctors' appointments, that's another one. You are correct, as well as assumptions of overeating. Yes, we tend to judge our patients. We tend to judge in the society as well when we see patients who are overweight or obese, and we went a little bit over the pathophysiology of obesity in our first session, and we saw that there are different components and different aspects that we also need to evaluate when we see our patients. It's not just that our patients are lazy or they are eating too much. There are other factors interacting that we need to also make sure that we take into consideration. Next slide, please. So there's different levels. Specifically, when we have patients, we have in the community, as I mentioned, these are institutional or structural level, as well as the interpersonal and the intrapersonal. So in regards to the institutional or structural, there are some policies that are not inclusive and sometimes discriminatory when for a patient with who are overweight. We have inadequate physical accommodations, and in some cases, we don't take seriously the complaints that we have from our patients because we associate and we link any health complaint of our patients because of their obesity or because they are overweight. In regards to the interpersonal level, we also have disrespectful communications. We attribute all symptoms to the patient's weight. We sometimes don't like to have this conversation with our patients because we are busy or because we have other patients that we believe are more likely to have better health outcomes. And so all these weight bias and stigma affect the communication with our patients, and therefore they also affect the health outcomes of our patients. So we need to make sure that when we have this conversation with our patients, we talk to them in a really polite manner, making sure that they understand the reason why we are talking about this, asking them for permission. And in regards to the interpersonal, it's very difficult for them to internalize comments, and this can bring other issues like depression or anxiety, or just the patient doesn't want to lose weight because they say, okay, if I am overweight or obese, I feel okay, I don't have any other symptoms. So they ignore the consequences of being overweight. Next slide, please. Weight stigma is prevalent in our society. There are several studies saying that about 40% of those who are overweight experience weight stigma. And for those, the range, in adults is between 19% to 40%. The first one that I mentioned includes teenagers and adolescents who are more likely to have other issues like bullying, and they are exposed to their friends and have peer pressure. But in reality, everyone who is overweight or obese has experienced some point, some type of weight stigma. Next slide, please. Now, this is an issue that can affect any patient regardless of their sex, their age, their race and ethnicity. I mentioned that in some cultures is more prevalent, to see this type of stigma, regardless of the sexual orientation, regardless of the body size or the nationality. In regards to body size, it's really interesting to see because we've been talking about BMI, but in reality, either a short person or a tall person can also experience weight stigma, maybe, and we need to make sure that we don't diagnose people because how they look. We need to use the appropriate tools to make sure that we are talking to a patient who is really having an issue, and making sure that we provide the resources and the correct diagnosis and the tools for this person to lose weight. Next slide, please. According to the American Diabetes Association, and specifically the standards of care in overweight and obesity, they have different, or they analyze different factors, and a specific on where stigma causes stress in our patients. And this stress is linked to eating and physical activity behaviors. Also, there is a physiological reactivity, and there are issues with the services that we provide to our patients. And I would like to focus on the third box, specifically related to the healthcare services, because when we have a weight stigma and when the patient perceives a weight stigma, we have poorer treatment adherence. Patients are not following the instructions that providers are given to them, and that is seen sometimes that the patient is not following the instructions, but in reality there is something behind which that sometimes we don't pay attention to, or we don't take into consideration, and is the weight stigma. So we need to have open conversation with our patients. Our third session is going to focus on motivational interviewing, making sure that we know how to speak to our patients and how patients can find a reason or something that can motivate them to lose weight. And what happens is that if there is not treatment adherence, patient also mistrust the healthcare professional. They don't. They believe that they are not receiving the right treatment, or they are not receiving the right care, and this is like a cycle. There is no treatment adherence because I don't trust the clinician. Uh, so if I don't trust, then there is no treatment adherence, and I don't see any progress, then I don't go to my follow-up visits. I If I don't go to my follow-up visits, it's not just now the care that we are providing to this patient because of their weight, but at the same time, the patients are missing opportunities to get preventive health screening. Remember, our patients also need colorectal cancer screening, or breast cancer screening, or diabetes screening, or if the patient is hypertensive, or if the patient has any other issues, the patient is not receiving the preventive services. And this is because of the poor communications that we're having with our patients. So this is extremely important, and specifically in healthcare services, and how we need to get trained, or we need to train uh, our providers and our non-clinical staff to make sure that the weight stigma is something that is not affecting the communication that we have with our patients. Then we have other issues. The patient has other, the stress also causes eating disorders, like lower motivation for exercise, less physical activity, and there are some physiological reactivity as well. We talk about the pathophysiology of obesity. And then what is going to happen is that all these three are going to get together, and what is going to happen is that our patient who we are talking about weight, the patient doesn't follow instruction, feel that it doesn't have any hope, and the patient start gaining weight instead of losing weight. So then this causes some psychosocial issues, depression, anxiety, low self-esteem, And there is also some health distress, and we see other issues when the patient starts gaining weight. We have poor glycemic control. The patient can get over hypertensive. The patient can have some other psychosocial issues, and the end result is a lower health-related quality of life. Next slide, please. So, quick question. Where does weight stigma occur? Where have you seen weight stigma in your experience? It's not only in the clinic. Kelly is saying the media, which is true. And the media is one of the first places where people are exposed to weight stigma. There are a lot of jokes and memes and all that things that the media is bringing, where people can feel that they are being or they are perceived as someone different, as someone who is overweight. So yes, Kelly, that's a place. Where else where the stigma occurs? Christine saying everywhere: airlines, media, when shopping, home, at work, social media, school. Yes, and you are right. I mean, it's everywhere and anywhere, and all these people are concerned about this, and this is creating a lot of depression and anxiety disorders, general anxiety disorders in our patients. Next slide, please. And so what is happening is that when our patients are having all these or are being stigmatized, if we look at the effect, first the patient feels that the patient is disrespected or judged or blamed. Then at the clinical settings, the patient doesn't have trust in providers if they perceive a provider who is judging the case or a condition because of their weight. Then this affects the communication. They reduce the quality of care that we provide to our patients. We have all these um, clinical quality measures that we are that we are reporting to HRSA, and even and if we don't have patients, if we have patients that are not coming to the follow-ups, if we don't have patients who are not adhering to the treatment that we are providing, of course that this is going to also affect our quality measures. And then there is an avoidance of undelayed of care and increased clinical attrition. So this is something that is affecting all patients, that is affecting us, not only, and it affects not only our patients, it affects also our clinic, it affects also our relations, our communication with our patient, it affects our clinical quality measures that we are offering. Remember that some of these patients also have obesity, or I'm sorry, some of our obese patients have diabetes or have hypertension, or they need other screening, or they are coming to the clinic for other type of a screening. So if we are judging the patients, if the patient is perceiving to being stigmatized or being stigmatized, we will also have issues when we take a look at the quality measures, at our quality measures. Next slide, please. Now, what patients say, what do they say um, in regards to the communication that they have with doctors or clinicians or nutrition or any other clinical person? I mean, and this is a study from the University of Connecticut. And the patients perceive that there is negative judgment, that doctors are or those providers are focusing on the weight, of the patient and not on other conditions. Sometimes they hear insensitive language. Sometimes we refer patients to obese patient, for instance, instead of saying a patient who is obese, even though it sounds similar, it's totally different how the patient is perceiving what we're saying. They don't receive the right weight loss advice. They are coming on to the clinic and they see and they compare to others in the community and say, hey, I didn't get this from the doctor, and why did you get it? Remember that there is interaction of our patients beyond the clinical setting. So if a patient talks to another patient and they perceive that they are not receiving the advice or the same advice that others are receiving, this person can feel or can that he is being he or she is being stigmatized, and then there are negative assumptions. We are saying we believe that all symptoms are due to weight. We are going to have a case study analyzing all these all the interaction of everything that we have, because we don't have really good communication with our patients, or because we make a comment that probably it was not appropriate, or not even in the clinic, but somewhere else. So all these we need to have open conversation with the patients. In the first session, we said is the first thing that you see when you see a patient. You see whether or not this patient is overweight or obese, and this is not, or this shouldn't be the last thing that we should be talking to our patient. We need to have an open conversation about the issues, and the weight of a patient should be one of the first issues that we should be talking to them. Next slide, please. There are several surveys and studies, and then specifically some comments from providers about some patients who are overweight. And the comments are that the patient is lazy, or the patient is not motivated, that you are providing prescriptions, that you are providing advice, and yet the patient is not following your instructions, or that the patient is lacking self-control, or the patient doesn't have the willpower, and that they are at fault for their weight. And there is poor self-management, and this is coming from all type of professionals, not only primary care, but specialists. So this is not something that is just happening in the community. Is also happening in hospital settings and in clinical settings, in primary care settings. We need to make sure that we have this again, the conversation that we need to have with our patients, be very respectful. We need to pick our words carefully, because our patients are very sensitive to the comments that we can make. The same type of sometimes we can extrapolate, and it's the same when we talk to an adolescent. We need to be very careful how we speak to our patients, because if the patient perceives that we are not being respectful, or that we are stigmatizing the patients, are not coming back to the clinic. Next slide, please. More information regarding how we talk to our patients, the role that the communication plays when we talk to our patients. But when a patient is stigmatized, um, they they are more likely to look for another doctor, or for another clinic, or go to another clinic, and they are more likely to avoid future appointment with my doctor. And when they say my doctor, can be any doctor, because what is happening is that they are going to stereotype providers as well. I don't go to the doctors because they don't understand my issue. And so we need to make sure, again, how we talk to patients and specifically or young patients, because parents are also looking. And in this same study, we see that patients are also more likely to seek or to look for new doctors or avoid future appointments if they see some type of a stigma or they perceive a stigma when we talk to our patients. Next slide, please. So the standards of care for patients with obesity has some recommendations. They do say that we need to implement protocols to minimize risk of a stigmatization during provision of healthcare services. We need to make sure that we have the appropriate equipment. If our clinic is not, if our clinic doesn't have the equipment that we need, make sure that we have anything that can accommodate all patients. And we need to make sure that when we are providing anthropometric measures or measurements, this is in a private place, that this takes in a private place where patients are not seen by other patients or by other people, but the person who is helping the patient. Next slide, please. This is the most important in my opinion, that we need to use person-centered, non-judgmental language so we can have the best outcomes when we have conversation with our patients. And again, there is an example. Instead of saying person with obesity, we can say a person with obesity instead of an obese person. We need to make sure that we engage our patients, that they uh, find solutions with us. We cannot come up with a list of solutions for our patients. This is a conversation that we need to have with patients. We need to individualize the treatment that we are providing to our patients, making sure that we understand why this patient is different and how we can help this patient. And again, we are going to have a session on our third session will be on motivational interviewing, how we can, and we are going to learn how we can discuss these issues, and not only obesity with our patients, but with other issues. We've done a lot of sessions on smoking cessation or alcohol misuse and motivational interviewing. And it can also be used for patients who are not following instructions, and making sure that we find, that the patient find something that is going to help them to avoid any outcome that is not the right outcome, the outcome that we are looking for our patients. And we also need to make sure that when we talk about weight, we need to talk to our patient, let them know that we are going to talk to about their weight, that this is something that is a conversation that we have with all patients. And in reality, when we are providing services to patients, even if they are not obese, the recommendation is eat healthy, exercise regularly, make sure that you follow your doctor's instructions. And if you have any issues, please come back to the clinic. So the message needs to be the same for any patient, regardless of, again, age, sex, weight, religion, or anything that we are that is going to affect any type of communication, and is going to be perceived as something that the patient doesn't want to hear from us. Next slide, please. So this is coming from the standard of care in overweight. We are going to share this slide with all of you, but it's more like what you need to do if you are looking for a checklist, if you provide services to to patients, making sure that you have everything that you need when you have conversation with patients, and the materials that you need to make sure that you have in order to provide the best services to your patients. Next slide, please. Again, this is coming from the same standards of care. In case you are looking for a checklist for these patients, this is what you need to have in the waiting room and the examination room, the type of tools and equipment that you need, and the training the staff needs to go over when if you are planning to have a program who is going to help patients who are overweight or obese. Next slide, please. So we are going to go over a case study now. We would like to hear from all of you. Interact, let us know what is wrong with the patient or what we should have done better. But let's talk about Maria, a 30-year-old school administrator. And her medical history is that Maria has mild asthma, chronic knee pain, and elevated blood pressure. The patient is hypertensive. She's active. She's a dedicated mother of two who works regularly, cooks at home, and is engaged in her community. Despite her efforts to stay healthy, she has long felt judged because of her weight, especially in healthcare settings. Maria visited your health center due to worsening of her knee pain, and she hoped to receive imaging physical therapy options for or an evaluation for joint instability. Instead, Maria, Maria's doctor glanced at her chart and immediately said that her pain is due to her weight, saying if you just lost some weight, your knee pain will go away. No physical exam was performed. No questions were asked about activity, injury, or family history, and Maria left feeling dismissed, unheard, and ashamed. Next slide, please. So let's talk about the impact of the weight assessment on the patient. What we did wrong, how is going to be the patient affected emotionally, medically, and behaviorally. Any comments? Please use the chat box, or if you would like to participate verbally, your line can be unmuted. But let's talk about our patient and what we should be doing to improve the services that we are providing to Maria. And Shimoke just added the case study to the chat box, and so we can focus on the questions. Um, from Christine, the PCP should ask the patient why she is in the clinic to give her a chance to explain her ideas for knee care. That's correct. Christine, that's one of the first things that the doctor should have done. There has to be a physical exam to see if there is an injury. That's exactly right. That the case study doesn't say anything about why the patient is experiencing any pain. So are we just judging the patient that because she is overweight, her knee is hurting, and therefore there is no need to offer a physical exam? Kelly is saying ask her about her daily activity. Lisbeth saying no proper assessment, lack of curiosity, no patient-centered care. Correct. All these responses are correct. Now, how are we going to affect our patient emotionally speaking? What issues can the patient experience because of the lack of communications that we're having? Yeah, Christine, you're right. Many people with who are overweight do not have knee pain. that's exactly right. I mean, the people tend to believe that because someone is overweight or obese, the person is going to have some issues with their knees, but in reality, there are many of them who are not experiencing knee pain. So from an emotional or behavioral perspective, the patient can feel first because she's been judged. The patient can present some depression on some anxiety disorders. So that's something that we can also be doing without even noticing. So let's make sure that when we have these conversations, we are not triggering any other issues in our patients. From a medical perspective, uh, the patient was coming for knee pain, but in reality, because the patient didn't receive any other services, we don't know what is the health status of our patient. We didn't get anything about whether or not the patient's sugar level is high. We don't know anything about, since this 35-year-old patient, whether or not she had a mammogram and when she had the last mammogram. We don't know anything about cervical cancer screening. We don't know anything about, or we couldn't get any other um, information from the patient because we focused on her complaint and we didn't address the complaint, but also we for we forgot that we are seeing a patient in a holistic way and not we are just focusing on specific issues that the patient is having at the time of of the consultation. Now, our second question, and I have seen already some responses, but how weight stigma appeared, and we heard from some participants, that we are linking the knee pain to the fact that the patient was obese, but did we ask anything about any injury that the patient had in the past, any car accident, anything else that could have affected the patient? But we didn't do it. So from that, from the very beginning, we stigmatized the patient and we linked the knee pain to their weight. Now, the next question is, okay, we did something wrong, but what the clinicians should have done different? Any comments here? Thank you, Alicia and Kelly. I think many of these were covered in our earlier comments. That is correct. Now, Alicia is saying, I'm curious about this. I have heard patients telling me that they are in pain and were referred to the surgeon and they were told they cannot be operated on due to their weight. I could be wrong in explaining this, but I remember something along these lines. Maybe it was a specific BMI, or maybe they were told they need to lose a certain amount of weight before they can be approved for surgery due to complications. It was one of the above. Just I cannot remember since I'm not a PCP. I don't know the protocol on surgery if a patient were to actually need surgery. Somebody who could who wants to chime in and talk to Alicia about this? Well, there are different things that we need to consider. I'm sorry, go ahead.
I was gonna say, I think Lisbeth tried to respond assess about physical activity, injury history, lifestyle, perform a physical exam. Mm.
Yes, and well, first, Alicia, we need to know the reason why the patient was referred to a surgeon. Probably the patient needed a knee replacement. I am just assuming that, and when there is going to be a surgery, there is a pre-surgery or some pre-surgery protocols that we need to make sure the patient needs to have some exams, including EKG. The patient needs to have the A1C, glucose level, and making sure that the patient is not going to have any complications. Weight can be a factor to consider, but it's not the only factor that we consider when we have a patient and the patient is going to have a surgery. So patients, if they are healthy, even if they are overweight or obese, they can go and have a surgery and undergo a surgery. But it will depend on the history and what other issues the patient is experiencing. Thank you so much. I think that's really good, and thank you so much for sharing your experience with your patient. So, what solutions? The number four is discuss evidence-based solutions. What can, what can we offer to our patient? Let's fix this, and let's say that this the patient is now in the clinic. Forget about the clinical history that we went over, and say what we should do now. Lisbeth is saying assess about physical activity, injury history, lifestyle, perform a physical exam. That is correct. All of the above, Lisbeth. I think that we need to first get the appropriate history from our patient. We need to ask some details. Time, is very important when the patient had since or when was the first time when the patient experienced this knee pain, whether or not it was linked to another condition or an injury or an accident. We need to know once we get all that information, we need to hear from the patient about his family history, any condition that the family or any history in the family. We need to uh, see what else can cause a knee pain in the patient. What are other factors that we need to consider? And Christine says there are definitely weight loss goals for people who are at higher weight or pregnant before surgery or delivery to avoid complication. With this, we see this in my area due to the fact that we are in an extremely rural setting. Oh, excellent. Excellent. Thank you so much for that. And yes, I mean, it will depend on the urgency as well, Christine. I mean, it's not the same when you have, a surgery that you have the time, to set some weight goals to your patients to minimize any complication. But I do agree with you, that that is some of the first things that we need to talk to our patients, in case they have an elective surgery. So then, in regards to evidence-based solutions, we need to go. I mean, if we are going to talk to our patients about um, her weight. Well, the patient needs an evaluation, a BMI. We need to find where she is, whether she is overweight, obese, or what type of obesity she has, either one, two, or three. We need to make sure that we develop some protocol for the patients, whether or not the patient can exercise. We can also scan for other determinants of health, the non-clinical determinants of health that could be affecting our patient. So all those are evidence-based solutions. And the last question that we have is, what do you find most challenging? And this is a general question. What do you find most challenging when communicating with patients about body weight? Anything that you say, okay, this is difficult to say, this is difficult to talk to a patient. Um, what is something challenging in in your practice or in your settings when you talk to someone and you are talking about body weight? Use respectful, non-judgmental language, correct, Lisbeth? That is something that we also have to consider. I think some challenges when I talk to patients, and sometimes I think the first challenge is to find some type of motivation. Sometimes patients do not understand that if they are obese or overweight, that can cause other issues in the long run and in the short run as well. It is also challenging when a patient, you need to be very careful and you need to pick the words that you are going to use when you're having this conversation with your patients. It's also challenging um, to set some standards for our patients. Each patient is different. We need to individualize the patient and making sure that if we are following a protocol, the patient can adapt to the protocol that we are offering. So all these are challenges that I've seen. Is there anybody else who's who's seen different challenges and would like to say, hey, this is what I've seen? And the other challenge, and you are also very familiar with all these, is that it doesn't, I mean, sometimes you can have the best communication with the patients about any issue and not talking only about obesity or overweight, talking about any chronic medical condition, but we need to also uh, find solutions to other issues, right? Like the patient doesn't have any insurance, so can we talk about follow-up visits or any other dietary guidelines or anything else? And if so, who is going to help the patient with the issue? Or the patient has housing instability. The patient doesn't have access to healthy food. Those are challenges that we have. Is we cannot focus on the individual without seeing the non-clinical issues that are affecting our patients. Uh, Getting them to see our cultural norms are not okay, fast foods so frequently, etc. Yeah, we need to go over uh, their diets and see whether they are receiving the right diet. So next slide, please. We are almost at the hour. So if any have any question or if anyone would like to say anything about this presentation, but in the meantime, if you have a question, Fide, please go ahead.
Mhm. Yeah. So just so everybody, if you have any questions right now, please, you can submit it through the chat. So let us know. In the meantime, while you think about any questions, I would just like to remind everybody to please provide your feedback and complete our post evaluation survey. Again, this information is always very helpful for us. Oh, and we also just received another comment from Lisbeth saying language barriers for non-English speakers and health literacy challenges. Yes. Thank you so much. And then also, this is just a kind reminder to everybody that our third session is also next week on Wednesday, the 25th, from 1 to 2 p.m., where we're going to be discussing motivational interviewing for nutrition and physical activity improvement. And this is our contact information. You may always contact us. Let's say if you have a question that just pops up in your mind out of nowhere while we're away, you can always email us here and we'll be very happy to respond to you. And that is it for right now. Since I don't see any questions here in the chat, I think we're good to go, and we look forward to seeing you all in the next session.
Thank you so much, everyone. Have a great afternoon.
Thank you for your participation. Have a good afternoon.
Thank you. Bye-bye.
Bye.